Good evening, everyone. We will start our session. Welcome to our session. My name is Dr. Tsaganesh Mokonnen. I'm joined with Dr. Miron Yafit. We're from Yetena CME team. Today we're going to be starting an amazing topic. And so before that, let me just tell you a little bit about Yetena in just a few minutes, and we're going to proceed with our presentation. Can you see my PowerPoint? All right.
Yes.
So let me tell you more things about Yetena. It's fully a volunteer network using a digital health platform, and we try to reach to the site as much as possible. It's registered in Pennsylvania, USA, and it has got nearly 150 active volunteer members, and we span around 5 different countries and we want to add more. The main work of Yetena is first we work on the health promotion, like we try to advocate for health in general public and the policy as well as implementation of health policy. We try to do for community engagement. Last time I think you have heard about our blood drive and volunteer activity during the September 9 and 10 activity. We try to fundraise and for different charities, as well as we have got this mentorship and skill sharing program where we try to connect health professionals with the experts so that they can do skill sharing and the like. And we've got one of the medical education part is the CME, and we've got the research in QI project. As you can see from this picture, some of them was from the activities we had on September 9, and this was we donated some headphones for patients with autism, and this was patients with disability, and we tried to learn some sign language, and this was our health and art activity we held on September, and you can see the blood drive activities. So we're more than a digital platform, and so you can see from these pictures we donated. We tried to collect notebooks and donated to charities, and these are our active members. So we had the Yetena and Health article writing, collaborating with Roha, where we try to motivate medical students to write health articles based on a local language, and we give them prizes. As you can see, this was on 2021 and this was on 2022, and so we appreciate if medical students try to write health articles so we can publish it. We've got it in our Roha Research Fellowship in collaboration with Roha Health and Tukur Ambassa Hospital, where we try to include 3 departments: oncology, radiology, internal medicine, and give them grant for 4 winners. You can see their picture here. 2 of them were from two was from internal medicine, 1 from radiology and oncology department. So we try to do the health education through research, and our CME, it's fully for free and accessible. So by far, with more than 30 webinars we held, and we got attendees ranging from 150 to 2,000 to 200. And this year we plan to focus on non-communicable diseases, mental health, and SRHR. And we try to invite world-renowned international speakers so that the health professionals get the updated and latest information. And today's session is in collaboration with EMA. And so if you want to access our previous CMEs, you can get from our YouTube channel. If you search it in you can see our previous CMEs and you can get updated based on that. So you can get so if you want to know our next CMEs, you can join us on Telegram, and you can follow us on our social medias. So just to tell you about our CME today, make sure to attend the whole sessions virtually. The minutes attended will be checked by Zoom attendee reports, and we'll be sharing a Google form at the end of the session, which will contain quizzes. So it has got 4 questions. Make sure to answer 50 of them. So pay attention to the session to get 50% and above. and we'll be giving you the 2 CU units. It might take 1 to 2 weeks, so be patient with us. I'd like to say thank you. So today's session would be with Professor Solomon. Let me tell you a little bit about Professor Solomon. Professor Solomon is a professor of psychiatry at the Department of Psychiatry at Addis University in Ethiopia, and he's a chair of Department of Psychiatry from 2020 to 2023. He held visiting scientist position at Harvard T.H. Chan School of Public Health, Department of Epidemiology from 2016 to 2020. His qualifications include degree of Doctor of Medicine, specialty certificate in psychiatry, subspecialty certificate in addiction psychiatry from University of Toronto in Canada, and Ph.D. in psychiatry epidemiology from Umeå University in Sweden. He's engaged in clinical work, teaching, and research. He has conducted epidemiologic research on psychosis, alcohol and drug development and adaptation of measurement tools, clinical trials, and service development for SRD in Ethiopia. He's currently a principal investigator of the neuropsychiatric genetics of African population psychosis, NeuroGAP-P, Ethiopia project, the largest human genetics research done in Ethiopia, thus so far recruiting 13,000 participants in collaboration with Broad Institute of MIT and Harvard, aiming to uncover the risk genes for psychosis, funded by Stanley Center and NIH. He's also PI of a new research project, Depression Genetics in Africa, DepGen Africa, a large multi-center genetics research led by the University of Edinburgh in the UK, aiming at expanding the risk genes for depression, funded by the Wellcome Trust. He has more than 75 publications in peer-reviewed scientific journals. He's editorial board member of the journal Psychiatry Research and serves as a reviewer for a number of local international journals. He's current executive committee member of African Association of Psychiatrists, member of section in addiction psychiatry, and honorary member of World Psychiatry Association, and has served president of the Ethiopian Psychiatric Association from 2014 to 2017. He's a fellow of Ethiopian Academy of Science. And without further ado, I would like to leave the floor for Professor Solomon. Thank you very much for joining us today. I know it's inconvenient, but I'd like to say thank you.
Thank you very much, Saganash, for the opportunity to share my knowledge and experience on addiction. We call it substance-related and addictive disorders. Good evening, attendees and coordinators. And I will be sharing my slides in a moment. So, can you see the slides?
Yes, we can see it.
Thank you very much once again, the organizers. It's really a great opportunity. I've been teaching this subject for more than 15 years. And I've been doing clinical work, including in public institutions. Recently, I have established my own treatment and rehabilitation center. We call it Renaissance Mental Health and Rehabilitation Center. So it's really a subject close to my heart, and I always enjoy teaching medical students, residents, and giving CMA on the subject. So the outline of my presentation includes the following. It may sound familiar to some of you, to those students who had my lectures in the past. Some of the material may seem familiar, but we have a number of new information in the slides. I start by defining addiction and its features, list the different types of addictions, and then focusing on psychoactive substances. And we'll be looking at the neurobiology of substance use disorders, and we'll look at diagnostic criteria and general principles of management. And I will be focusing on 3 substances which are common in Ethiopia and which we see in our clinics in the general medical setting as well as in mental health practice. These are alcohol, chat, and tobacco, and prescription drug misuse. And I will discuss substance use among physicians because it's also one of the common problems that we see nowadays. In addiction psychiatry, we use the term addiction, but DSM doesn't use the term addiction, but it's really a very important concept that captures, an important health problem. So it has its own origins. Addiction is derived from the Latin verb addictus. It's an interesting term because it denotes some loss of liberty. Back in the days during the Roman times, when someone is indebted to somebody else, and if he cannot pay back the money, the person will be subjected to slavery. So paying back in the form of service, in the form of slavery. So that person would be sentenced to addictus, meaning the person would lose his liberty and serve the person who owes, who lent him money. So that sense, sense of loss of liberty and enslavement is what denotes, the term addiction. So when someone has addiction, it's a figure of, speech in a way. The person loses his freedom. So addiction is equivalent to loss of freedom. So when a person has addiction, he would literally lose his freedom. He will be in bondage in a way. It's a tough description, but it's a fact, and I see this every day in my patients, how strong the attachment is. So that is the origin of the term. And the National Institute of Drug Abuse defines addiction as a chronic relapsing brain disease. So when someone has addiction, there will be changes in the brain. So that results in a disease condition. And then it's chronic and relapsing. And the person manifests compulsive drug seeking, craving, loss of control, and impaired decision making. So these are significant derangements in the person's self-control and self-regulation and behavior regulation. So and a person engaged in pathological pursuit of reward or relief by substance use and other behaviors. So it's a pathological pursuit of pleasure. It's not a healthy pursuit of pleasure. And we have two types of addictions. The first one is addiction to alcohol and drugs. We call them substance. And behavioral addictions. Behavioral addictions can be anything that gives a person high or pleasure. So we say any pleasurable experience is potentially addictive. Any pleasurable experience is potentially addictive. For instance, gambling can be addictive, sex can be addictive, shopping, internet, even physical exercise can be addictive. But DSM-5 recognizes only gambling disorder as behavioral addiction, and the rest are under investigation, and in subsequent editions, we expect addition of a number of behaviors, including internet and so on. So just to remember, addiction, in fact, the core feature of addiction is loss of control. So if a person has loss of control over his behavior, we can say that person has addiction. But there are three C's. The first one is compulsive use, meaning the person will have a strong urge, which is difficult to control. And then loss of control over how much or for how long the person engages in the behavior. And the third one is continued use despite adverse consequences. So compulsive use, loss of control, and adverse consequences are the three C's that are features of addiction. And if you look at the DSM-5 classification of different substances in alphabetical order, you have alcohol, any beverage which has alcohol content, cannabis, caffeine, stimulants, sedative hypnotics, anxiolytics, opioids, inhalants, hallucinogens, and tobacco, and other prescription and non-prescription psychoactive substances. But these are the common ones. So what are the characteristics of addictive substances? We wouldn't call them addictive if they don't have pleasurable effects. So when the person uses psychoactive substances, the first experience is a high, we call it a high, or a pleasurable effect. And the effects are rapid in onset and therefore particularly reinforcing, especially when taken IV. Parenteral use has the highest reinforcing effect, followed by smoking, and then ingesting orally. So the mode of ingestion or the mode of intake affects the strength of reinforcement. And with repeated exposure, tolerance occurs as a neuroadaptive response. When a person exposes himself to substances, to a particular substance or multiple substances, over a period of time, there will be a process of neuroadaptation, and we call that tolerance. And the most important neurobiological process in the brain is resetting of human pleasure. As you know, dopamine is the neurotransmitter that is released or activated when a person takes psychoactive substance. And whatever we normally do as leisure can increase the level of dopamine in the brain. For instance, when we take a walk, simple walk, physical exercise, food, even watching a movie, laughing at a joke, all these release dopamine in the brain. So these are what we call normal, healthy highs, including sexual intercourse. When people take psychoactive substances, the threshold for experiencing pleasure becomes higher and it becomes reset. So these people lose pleasure from these natural highs. And I will come to that later in the discussion of neurobiology. And we call this process hijacking. So you can go back to the definition of addiction: loss of liberty, loss of freedom. So when someone has addiction, he has lost his freedom. His brain is hijacked, we say. So addiction is a process of hijacking of the brain by some chemical or some behavior. I think this is probably the most important definition of addiction. And why do people develop addiction? There are different processes and risk factors. If you look at the biological risk factors, we have genetics. So now, beyond reasonable doubt, because of the development of the science of genetics, we have come to understand there are a number of genes that are affected because of addiction, and these can be inherited. So heritability is important. In fact, if someone has alcoholism in the first degree relative, the probability of or the risk of developing alcoholism in the offspring is 2 to 4-fold increase. So that means there is genetics. And epigenetics. Epigenetics is a process of developing new genetic changes due to environmental risk factors. So when people are exposed to different substances, there will be changes in the genetics, which eventually will be transmitted into the offsprings. There are different medical conditions as well, which lead to the development of addiction. For instance, chronic pain. Many people who have chronic pain develop addiction because of pain management. They take opioids for pain, and they eventually become hooked to these pain medications. And in the US now, It's of epidemic proportions. There is a opioid epidemic, and 70,000 to 100,000 people die every year because of opioid overdose in the US, which is really a serious epidemic nowadays. So biological. We have psychological risk factors. People who have different problems in their psychological makeup. For instance, low self-efficacy or low self-esteem, poor coping skills, different mental health problems, psychological trauma can predispose individuals to substance use. And these are really very well-known risk factors. And if you look at the social risk factors, the presence of or absence of education can be a risk factor to some addictions. You will not find people in the countryside addicted to opioids, for instance. It's an urban elite or educated people phenomenon. But poverty can also lead to different addictions. You know, whether you are in the higher socioeconomic status or in the lower socioeconomic status, there will be vulnerability in one form or another. Disruption in the family, as well as substance use in the family, can lead to addiction as well. Legal issues can also affect addiction. And if you look at the criminal justice system, there are many people who are incarcerated because of addictions. And in most of illicit transaction of different substances is also common. The other one is use history. Age of onset is the most important risk. And people who start using substance before age 20 have the highest risk of being addicted for the rest of their life. And the pattern of use, everyday use versus occasional use, and the intensity of use, meaning having a couple of puffs versus finishing a torpedo joint, cannabis joint. If you look at just the heritability risk varies from substance to substance. And the first one is sedative hypnotics, 29 to 58%. Opioids, 43 to 60% heritability. Stimulants, 42 to 79% heritability. Hallucinogens, 39%. Cannabis, 51 to 59%. Nicotine, 28 to 84%, very wide range. And alcohol, 50 to 70%. So you can see genetics plays an important role, but the environment also is very important. So it's a combination of genetics and environment that leads to addiction. Neurotransmitters, dopamine is an important hormone, important neurotransmitter. You can call it with different names. The mainstream media wants to call it hormone, but we call it a neurotransmitter. A neurotransmitter is a chemical that is released from a presynaptic neuron to a postsynaptic neuron to activate the postsynaptic neuron. So that activation of a series of neurons results in some output. It could be emotional output, it could be cognitive output, it could be behavioral output. So dopamine, yeah. So if you eat food, you can see the amount of dopamine released is relatively modest. You know, you see these orange bubbles, these are dopamines released in the synapse. Modest amount of, but it gives good feeling. You know, when you have a nice meal, you feel good. Dopamine is responsible for that. If someone takes cocaine, you can look at the amount of dopamine in the synapse. So if we look at the proportion of dopamine flow with different things, for instance, when you eat chocolate, the dopamine increases by 50%. When someone has sex, dopamine increases 100%. When someone smokes cigarette, nicotine, 150%. When someone takes amphetamines or cocaine, dopamine flow increases 1,000%. So that means this is when someone repeatedly exposes himself to stimulants like amphetamines or cocaine, the brain pleasure experience gets reset. That means the person will no more enjoy sex, no more enjoy eating chocolates or normal pleasure. That's what hijacking is. The brain gets used to bombardment of dopamine, and a small amount of dopamine will not cause any pleasurable experience. And if you look at the different processes in the brain regions, we have the prefrontal cortex, which is responsible for behavior regulation. This part of the brain really what makes us human. It's a site of rational thinking, judgment, planning, execution, and so on, and behavior regulation, inhibitory control. And we have the basal ganglia, which are really the centers of emotion, including the amygdala, which is a powerful storage of emotional experience, emotional memory. So in the addiction cycle, we have binge intoxication when the person takes a large amount of substance. When it diminishes, a state of withdrawal or negative affect happens. And then there will be preoccupation and anticipation, which results in craving and binging again. So this is a cycle. In binging or intoxication, when the person takes large amount of substance, this is what we call incentive salience, meaning the person becomes intoxicated, high, intense emotional experience. And you can see the neurotransmitters that are involved, predominantly dopamine. So when the person experiences high, dopaminergic neurotransmission is highly activated. And when the person is in a state of withdrawal or negative affect, this is what we call reward deficit. In this state, mainly cortisol, which is a stress hormone, the person experiences intense negative emotion and stress. So corticotropin releasing factor is released, and then cortisol and other neurotransmitters which are stress related are released. So the person experiences dysphoria, irritability, depressed mood, low energy, lethargy, and so on. So this is what we call reward deficit. The other one is preoccupation and anticipation. This is a cognitive part of the brain, meaning the person starts thinking about the experience and then starts to think about using again. And in this case, it's a cognitive process. And then it's in the frontal lobe. And the neurotransmitter involved is glutamate. So these processes operate at different levels. And then the amygdala is also powerful in reuse, because the person starts thinking about the experience, and that experience is stored as an emotional memory. So emotionally charged material is stored in the amygdala, and it's very difficult to forget. And in fact, this has been demonstrated using functional brain imaging, SPECT. And if you look at this picture, when a cocaine addicted individual, when they show the person nature video, there was no activity in the amygdala. But when they showed the person cocaine video, the amygdala was on fire. So that means the amygdala gets activated when the person is exposed to a memory cue. So that triggers a very strong urge, which is very difficult to control. The person eventually engages in substance use behavior. One of the neurobiological changes that happen in the brain with repeated exposure, the brain becomes really hypofunctional. If you look at this brain, it's a functional brain imaging. A healthy brain has optimum activity, and a diseased brain or cocaine use disordered brain has diminished activity. You can see the bar. So the brighter colors show high brain activity, and the blue and the black colors show low brain activity. So in the cocaine brain, you have low brain activity. So this is one of the neurobiological changes. But the good news is, if a person is abstinent from substance, the brain function becomes normal with time. So if you look at this, this is a healthy brain, which is a controlled brain. Again, this is a functional brain imaging. A methamphetamine addicted person's brain, you can see hypofunctioning in the brain. But with 14 months of abstinence, that's a little over a year, the brain function becomes normal. So they have hope for restoration of brain function with abstinence. So we encourage people to abstain so that their brain function normalizes with time. Okay, so this is about neurobiology. When we look at substance use in Ethiopia, generally it's an emerging issue. Of course, some of the substances have been with us from time immemorial, like alcohol, chat, and tobacco, and then to some extent cannabis in the form of faris. But other substances are on the rise, like cocaine, and then a number of other substances. I see young people using ecstasy, LSD, and then crack cocaine these days, which is really a new phenomenon for Ethiopia. We have done a national survey in 2015 to study the prevalence of substance use in Ethiopia, involving over nearly 10,000 adults. So the percentage who currently smoke tobacco daily was 6.2% for males and 0.2% for females, and giving an average of 3.5%. So addiction or substance use is predominantly a male behavior. When we looked at heavy episodic drinking, it was 20.5% in males. That means 1 in 5 or 20 out of 100 males who consume alcohol engage in hazardous heavy episodic drinking, while the prevalence in women was only 2.7%, giving us the average 12.4. The percentage who currently chew chat males 21.1%, females 9.4%, and the average is 15.8%. So for chat, it is slightly higher in women compared to tobacco and alcohol, maybe due to cultural reasons. I have done a review of substance use among undergraduate students in 16 institutions of higher learning in Ethiopia. And then I found that current alcohol drinking was nearly 27%. So 27% of undergrad students reported drinking alcohol. Tobacco smoking was about 7%, and chat chewing was about 13% in undergraduate students, including students in the Anbassa. So the clinical aspects, we have two categories in DSM-5 for substance-related disorders. The first category is substance use disorders, and the second categories are induced disorders. So for use disorders, we have some key concepts: problematic use, and it has to be present in the past 12 months, within the past 12 months, and we need at least 2 of the 11 criteria. So the first category of criteria include impaired control. In impaired control, we have 4 large amounts taken or over a longer period than intended. That shows loss of control. Unsuccessful attempt to cut down or quit, time wastage, and craving. These are the 4 control-related criteria. The second category is social impairment, including failure to fulfill major role obligations at work, school, or home, persistent or recurrent interpersonal problems, important social, occupational, or recreational activities reduced or given up. And the third category are risky use, including use in hazardous situations like drinking and driving, and then continued use despite the knowledge of having a persistent or recurrent physical or psychological problem that is caused or exacerbated by substance use. And the last one is pharmacological criteria, or criteria that suggest neuroadaptation. These are tolerance and withdrawal. So when someone scores 2 to 3 out of the 11, we say mild substance use disorder, 4 to 5 moderate substance use disorder, and 6 and above severe substance use disorder. Substance-induced disorders are secondary psychiatric complications mainly. They can also cause or predispose individuals to medical complications like alcohol-induced liver cirrhosis or lung cancer due to tobacco. But we pay attention in psychiatry mainly to psychiatric complications. So essential criteria include temporal relatedness. These disorders should develop during active use or within 1 month of cessation. And the most important criteria is from research evidence. The substance has to have the capacity to induce the disorder. And we have to exclude other causes. For instance, we say alcohol-induced depressive disorder or cannabis-induced psychotic disorder. How do you evaluate persons with substance-related disorders? We have different interview techniques, but generally we have to use non-judgmental approach. We have to be mindful of our values. As you know, addiction is a heavily value-loaded subject, so people are judged, criticized, and then we have to be as neutral as possible. Avoid projecting your values. We have to build rapport. We have to be empathic, and the use of open-ended questions. And there are some other techniques as well, because minimization and denial are the hallmarks of addiction. So when you have interaction with our clients or with our patients, they usually minimize the problems. They also deny sometimes, especially if they are mandated. If somebody or family or the police, whatever, for whatever reason brings them to our attention, they may deny the use. So We use reflection techniques in our interview and rarely confrontational when there are inconsistencies. Collateral information is very important. And of course, the DSM-5 criteria for use and induced disorders are very helpful. We can use screening questionnaires like addiction severity index, audit, assist, and so on. But these are usually used for research purposes. A thorough history physical exam is very important because these are toxic chemicals that are taken into the body. So there are different physical health complications like, for instance, alcohol-induced liver cirrhosis or a number of other physical health complications. And mental status examination is also important. A person may be intoxicated or in a state of withdrawal, or there may be induced psychiatric conditions or concurrent disorders. Lab investigations are important to determine use, to assess complications, and to track treatment progress. So we can use samples like blood, urine, saliva, and in some sophisticated labs, hair samples can also be used. And then to assess complications, imaging like ultrasound is very important, especially in alcohol, liver function test. To track progress, we use the urine drug screen for patients on methadone or patients on follow-up, or to see progress in people who have alcohol disorder. Mean corpuscular volume can be checked. Liver function test can be followed. Ultrasound of the liver can be followed also to see improvement. If you look at the American Society of Addiction Medicine multidimensional assessment, there are 6 dimensions. You can look it up in the internet. I will tell you briefly. Dimension 1, so when we do assessment, according to ASAM, we have to use different dimensions. The first dimension is acute intoxication. So we have to check if there is intoxication or withdrawal. The second dimension is if biomedical dimension. If there are any physical health complications, biomedical. The third one is emotional behavioral, meaning mental health assessment. The fourth one is readiness for change. So is the person ready for change or ready to change? The fifth one is relapse, continued use, continued problem potential. So is there a history of relapse? What are the problems associated? And the last one is recovery or living environment. So we explore the psychosocial milieu or the environment, which facilitates recovery or which hinders recovery of the individual. For instance, a person who is on the street versus a person who lives with his family, they have different recovery potential because of the psychosocial support they have. So we have 10 treatment approach. The first one is information and understanding. So diagnosis is very important. Multidimensional assessment gives us a very good perspective. Acceptance and engagement. Once we establish this, we initiate treatment. That could start with detoxification, and we can use different pharmacotherapies for detoxification. We can also use pharmacotherapies for relapse prevention, different psychological therapies, including motivational interviewing, cognitive behavioral therapy, community reinforcement approach, CRAFT, meaning community reinforcement approach, family training. These are behavior-based interventions and contingency management, and so on. So there are a number of therapies. In general, these therapies are divided into 2, either cognitive-based or behavior-based predominantly, or combining the 2. And we need to also diagnose and treat comorbidity. It could be physical comorbidity or mental health comorbidity. And we have to also mobilize family and social support. And very important, but a challenge in our country is self-help fellowships. In the developed world, these are really very powerful treatment for people in recovery. Aftercare is also very important to maintain sobriety after a person undergoes treatment. And lifestyle and environmental changes are also very important to achieve recovery. So if you look at the treatment process, this is a general outline. Of course, you know, the majority of people have no addiction. I think this is the most important. Even among young people, you know, you may find as high as like 85% of young people having no substance use disorders, which is really very encouraging. So we have to maintain those young people free of substance. And for those who have substance use disorders, diagnosis is important. They have to be assessed and they have to be treated. So intervention, detoxification, early recovery skills. This takes 0 to 4 weeks. And then rehabilitation. Once they are stabilized, rehabilitation can take 4 weeks to 4 months. In our rehabilitation center, people stay a minimum of 4 weeks and a maximum of 3 to 6 months. And then once they complete the rehabilitation program, it's a maintenance. So maintenance starts from 12 months to several years. We say, in fact, in addiction psychiatry, recovery is a lifelong process. So different interventions can help. For instance, as I said earlier, the 12-step fellowship or self-help groups are powerful tools for maintaining sobriety. I have encountered during my fellowship training in Canada physicians who were in recovery. And I remember one psychiatrist who told me he had been attending Alcoholics Anonymous meetings for 22 years. So he told me he was in recovery for the past 22 years. And he will be in recovery until he dies. So that means recovery is lifelong. A person can relapse after 20 years of abstinence. Relapse can happen at any time. So relapse prevention has to be a very important focus during recovery. Relapse is, of course, common in non-communicable diseases. Communicable diseases can relapse as well in different forms. This is from National Institute of Drug Abuse. If you look at different chronic conditions, we know they relapse. For instance, we see DKA in diabetic patients every now and then. And asthma relapses. So in substance use disorders, the relapse rate is 40 to 60%. In hypertension, 50 to 70%. In asthma, 50 to 70%. Many people focus on relapse of addiction, forgetting that all chronic diseases do relapse. So if you look at the definition of the National Institute of Drug Abuse, addiction is a chronic relapsing brain disease. So it's like any other chronic disease. A relapse is the rule than exception. It's common, it can happen, but it's treatable. So I'll go briefly into the common substance in Ethiopia. Alcohol, it's our number one problem. It's a number one problem globally. It's responsible for over 200 diseases and injury conditions. It is a number one killer when it comes to substance. It's the number one cause of morbidity. And the screening for alcohol is very important in any adult consultation clinic. Key concepts to know. One is standard drink. The standard drink is the alcohol units in a particular alcoholic beverage. So it measures the amount of alcohol, not the amount of liquid in the alcoholic beverage. So to calculate unit of alcohol in any beverage, suppose you grab a bottle of beer, and if you want to calculate the amount of standard drinks or units in the beer, you can calculate the volume in ml multiplied by the percent of alcohol that is written on the bottle divided by 1,000. Then you can find how many units you have in that particular beverage. For example, one small bottle of 4.5% alcohol, beer. The volume is 330 ml. You multiply it by 4.5 and divide it by 1,000, you get 1.5 units. So a small bottle of beer, 4.5% alcohol, gives you 1.5 standard drinks. So you can calculate for any alcoholic beverage. When do we say a person exceeds moderate risk? For males, it's more than 5 standard drinks. Just a moment, sorry. For some reason, yeah, it escaped. Anyway, I
It's not on the slide.
to put the number.
Yeah.
So can you see the slides? Okay.
We can
Yeah, a
see.
number is missing here.
Yeah.
So it's supposed to be 5 or more standard drinks. So here 5 is missing. I apologize. So for males, consumption of 5 or more standard drinks or units in one drinking episode is considered above moderate risk, or heavy episodic drinking. We also call it binging. 5. So 5 is missing here. I'll put it later. And for females, it is 4 or more standard drinks per drinking episode. And we can screen people for alcohol use disorder in our busy clinics using the National Institute of Alcoholism and Alcohol Abuse, NIAAA single question screen. So using just 5 or more for men, here it's correctly written, and 4 or more for women. If they report consumption of 5 or more standard drinks per drinking episode, they are exposed to alcohol-related risks. So yeah, you can also use audit C, an abbreviated version, short version audit, or a full audit for screening. For alcohol, in our busy clinics, we can use brief intervention using the acronym FRAMES. FRAMES stands for feedback, responsibility, advice, menu of options, empathic understanding, and self-efficacy. So for instance, you check, the MCV, or in complete blood count, you see MCV 110 in an adult, and then you suspect the person has problematic alcohol consumption. So you tell the person, look, your blood is abnormal. Your red blood cells are abnormal because of alcohol. So unless you stop alcohol, your body will be affected. So this is a simple feedback, personalized feedback based on result. We don't just lecture or educate them about alcohol. We just give them personalized feedback based on our investigation. It could be lab investigation, it could be from the history or physical examination. So I think I will rush a little bit because of time. So brief intervention, giving personalized feedback, emphasizing personal responsibility, and then providing customized, very specific advice, and then a menu of options for action. So the person can choose whatever course of action, and this has to be done in the context of empathic understanding and encouraging self-efficacy. So these are really important and powerful package, and it takes about 5 minutes if you do it efficiently, and very useful in busy clinics, and there is evidence for a decrease in heavy consumption. So there is a research evidence on this. Clinical management includes, intoxication management is obvious. Alcohol withdrawal also has, many people have familiarity with that, using benzodiazepines and then thiamine. These are the two important biological interventions, and including nutritional support, and the prevention of Wernicke's encephalopathy is also very important. If it is diagnosed, then it's an acute neuropsychiatric syndrome, and it has to be managed using parenteral thiamine. Withdrawal seizures are also common, so they have to be managed with IV diazepam, but there is no need for continuous anti-epileptic drugs. Delirium tremens is a serious complication of withdrawal, and it has different manifestations, and then the management depends on predominant symptoms. There are FDA-approved medications for relapse prevention for alcohol. The first one is disulfiram. It blocks aldehyde dehydrogenase, which creates, accumulation of a toxic chemical, which makes the person very sick when consuming even a small amount of alcohol. So in the West, when they prescribe disulfiram, they make the person sign a consent, because some fatalities have been reported in some individuals. The reaction can be very severe. Naltrexone is an opioid mu receptor antagonist. It diminishes or eliminates the pleasurable experience from alcohol, which discourages people from consuming alcohol. And acamprosate is an interesting medication. And the formulation is also very interesting. It's 666 milligrams. The tablet is 666. So for some reason, I don't know why they chose this particular number, because of its significance in some religions. But it's a powerful medication for relapse prevention. Mechanism is not clearly identified, but it's FDA approved. Alcohol and health, very controversial. Many people say small amount of alcohol has health benefit. It's also found in the literature, including textbooks in internal medicine, right? But the recommended amount is extremely small. Maybe 1/3 of a small bottle of beer, or half a small glass of wine. These are really difficult to maintain. Many people pass that amount and end up, on the other end. In fact, there was an article in one of the cardiology journals, which described alcohol as a double-edged sword, meaning on one edge, if you take a very small amount, it can have cardioprotective effect, but mostly the reverse happens. When someone passes that limit, it cuts the heart. So it's a double-edged sword. Okay, chat. It's a very important problem in Ethiopia. We know Ethiopia is the largest producer of chat, and it's also the origin of chat. So we need to know about this. It has mental health as well as physical health complications. And there are different psychoactive chemicals in chat, and cathinone is the most potent psychoactive chemical in cat. But there is paucity or scarcity of evidence on the mental health and physical health risks associated with cat. We have evidence, from cross-sectional studies, retrospective studies, and so on. But prospective studies are lacking because of ethical and other limitations. Generally, cathinone, pseudoephedrine, and cathin, these are stimulants, and they are sympathomimetic psychoactive chemicals. So cardiovascular effects have been described. When pregnant mothers chew khat, they, experience miscarriage. Miscarriage happen because of vasoconstriction, low blood supply to the embryo or fetus, and IUGR has also been reported because of low blood flow. These are vasoconstrictors. So obstetric complications, cardiovascular, and CNS complications have been reported as well. Strokes have been reported especially from Yemen. And mental health complications include, as we know, stimulant use disorder, according to DSM-5. Khat is included in DSM-5. In fact, if you read the big book, you will find khat in DSM-5. So it is in the stimulant use disorder. And we have stimulant-induced disorders as well. So it's mental health impact is well established. Tobacco, everybody knows tobacco, so I will not go into the details. But tobacco is really one of the most important risk factors for non-communicable diseases, cardiovascular disease, respiratory disease especially, cancers, and many other chronic diseases. So management approach for tobacco, we have the 5 A's. So general physicians can use these 5 A's. We have to ask every adult, especially males, about smoking tobacco. And we need to give them advice to quit. And we need to assess their readiness to quit. And we have to assist. So ask, advise, assess, assist, arrange follow-up. Assist in the form of brief counseling or referral to a psychiatrist or an addiction psychiatrist for possible pharmacotherapy. For instance, in our rehab center, we provide tobacco cessation treatment using nicotine replacement therapies. We have nicotine patches and nicotine gum. So we provide pharmacotherapy for people who have tobacco use disorder severe. Okay. So if you look at pharmacotherapies for tobacco use disorder, you have nicotine gum, nicotine patch, nicotine lozenge, nicotine inhalers. So we have nicotine gum and nicotine patch. And non-nicotine pharmacotherapies also are available. These are medications like varenicline and bupropion. When you look at the effectiveness of these therapies, psychotherapy alone doubles the quit rate. When you combine psychotherapy with pharmacotherapy, quit rate triples. So it's powerful when you combine therapy with these interventions. Prescription drug misuse, common in the healthcare setting. Benzodiazepines and opioids are the 2 most commonly misused prescription drugs. As I said earlier, in the US, in 2020 alone, 70,000 people died from opioid overdose. So they are really struggling. And in our country also, interestingly, tramadol has become a major recreational drug among the youth recently. And of course, we know pethidine and morphine have been misused. So we need to be careful. These are mostly iatrogenic. So physicians introduce lay people or patients to these drugs. So when we recklessly prescribe these drugs, we're causing, iatrogenic addiction. So we have to be careful. I'm coming near the end. substance use among physicians, it will not be fair while discussing addiction not to talk about this, because we are particularly vulnerable as healthcare professionals for various reasons. Why are physicians particularly vulnerable to substance misuse? The first one is medical profession by its nature is a stressful job. And there is a high rates of burnout. This has been demonstrated by different research results, including studies done in Ethiopia. High rates of suicide, more than any other profession. Alcohol and drug addiction is at least as common, if not more common, than the general population. In US, for instance, 10 to 14% of physicians suffer from addiction to drugs or alcohol during their careers. I have been thinking about conducting research in Ethiopia for the past 10 years. Unfortunately, I could not do it for some reason, but if anyone is interested to collaborate with me, I'm happy to do this study, substance misuse among physicians in Ethiopia. It's a very powerful research, which will, help many physicians, because under my care, I have a number of physicians who have had, different addictions, including, alcohol and chat, cannabis, prescription drugs like opioids, and so on. So we have to do this research. What predisposes physicians to substance misuse? I have already described the profession, but like any other individual, there are family history, trauma history, untreated anxiety and depression, physical health problems. These are really, physicians are human beings. So any adversity, psychosocial stressors that affect other human beings affect physicians as well. And the job-related ones I have already discussed. Especially the most important risk factor is knowledge and access to psychoactive substance, especially prescription medications. Physicians can easily access opioids, for instance. How to recognize addiction in a colleague? In the developed world, for instance, in Canada, where I did my fellowship, in fact, I had the privilege to observe healthcare professionals groups who were mandated, who were forced to undergo treatment. So I had the privilege to attend their treatment sessions. If a physician has addiction or substance misuse, and if a colleague recognizes that or notices that behavior in a colleague, the physician has an obligation to report to the authorities. If you fail to report, that's unethical. And in fact, it's in their ethical guidelines. So they usually report their colleagues, and they suspend their license and mandate them to treatment until they are free and certified. Once they are free and certified, they get their license reinstated and they go back to practice. That's how they do it. So it's really very, very strict system. But in Ethiopia, as you know, there are many physicians who have different addictions and they still practice. There is no system in place. But, forget about the system, the ethics, and so on. For now, we have to help our colleagues. So if you recognize substance misuse in your colleague, in a physician, you can approach them. You can, empathically approach them, give them feedback using frames. And you can also refer them to psychiatrists who can provide them, the care in a confidential and humane way. So how do you identify, substance misuse in a physician? There are subtle signs. For instance, relatively rapid decrease in a colleague's competence at work, deterioration of competence, a new founded tardiness, the person becomes slowed, and the person becomes irritable, deteriorating personal hygiene, social isolation. When you see these subtle, signs in a physician, you can approach the person. What's going on? I see these changes in you. Is there anything that I can do? Can I help? Kind of. So these diversion programs happen in many countries. In Ethiopia, not yet, but at some point this will come. Diversion programs are treatment programs for physicians. We need these kind of services. We cannot put, physicians in the mainstream healthcare. They have to have safe, confidential treatment programs because of stigma associated with substance use. As I said earlier, we can empathically confront them, Empathy is very important. I think that's a key term. If you look at this picture, this is an Ethiopian doctor who was under my care. A very sad situation, as you can see, these multiple ulcerations. These are injection site wounds. This person had pethidine addiction or pethidine use disorder, severe. You can see how damaged his skin is. This is the upper extremities. Same with the lower extremities. He had even wound on his genitalia because he was injecting himself on the genitalia as well. So this is a kind of damage that you can see in physicians or in doctors who have opioid use disorder. And we have lost many of our colleagues for opioid overdose. And in fact, I heard recently a healthcare professional who died from opioid overdose. Very sad. So when you identify a colleague, a healthcare professional who has substance use disorder, do not hesitate to approach and suggest intervention. I think this is what we can do for our colleagues. So in summary, psychoactive substance misuse is a common problem globally, especially among the youth who tend to suffer more long-term. Neurobiological processes have been identified which help us understand the mechanisms of addiction and molecular targets for intervention. Evidence-based diagnosis and management protocols for SRLDs are available. Primary prevention, obviously, is the best approach. And physicians with addiction need special programs for treatment and rehabilitation. This is the message I have. These are for further reading. Thank you very much. If you have any questions, you're most welcome.
Thank you, Professor Solomon, for such an insightful presentation. So these are so we have 9 questions that has been thrown by the attendees. Starting from the first question, they wanted to know about.
Yeah, I can read the question. So,
all right.
You want me to proceed?
Yes, you can proceed.
Okay, thank you very much. Thank you, participants, for your interest in the topic and for your active participation. And then the questions are very relevant and very important. So the first question is homeless street children in benzene use. These are, benzene belongs to these hydrocarbons. We call them inhalants. If you remember my slide on the different psychoactive substances, inhalants are a group of psychoactive substances that contain hydrocarbons. So they are volatile chemicals, and they have a psychoactive effects, similar to nearly alcohol. So they are sedatives. They give a high at the beginning, but eventually they sedate, and long-term use can lead to persistent, neurodegenerative effects in the brain, resulting in, persistent amnestic disorders and so on. So treat kids in Addis use mastish nowadays. In the old days, it used to be benzene, but benzene is, it is highly volatile, but mastish is somehow, or glue somehow is solid, and then it stays longer. So they put in water bottle plastics, and then they sniff it all day, and then it gives them a buzz, a high, and then at the end of the day they become sedated and they usually sleep on the street. In fact, in Addis Ababa University, we have a new research project trying to understand why these young kids on the street use this particular substance, the factors that lead to streetism, and also how to help them. So we're planning to do multidisciplinary research and design pilot intervention, which can be scaled. So I hope something good will come out of this project. We already have the funding and we have submitted our proposal for ethics approval. That's what I can say regarding question number 1. Question number 2, based on the severity of substance and drug degree of addiction. I have already mentioned this in the substance use disorders. It's a spectrum. So we have mild, moderate, and severe. So based on the 11 criteria, when someone scores 2 to 3 out of 11, we say the person has mild substance use disorder. Because in DSM, we don't use the term addiction. We use substance use disorder. It could be alcohol use disorder or cannabis use disorder. 2 to 3, mild. 4 to 5, moderate. 6 and above out of the 11 criteria constitutes severe substance use disorder. So that's what the severity is about. Lab investigation done from hair. This is a very interesting question because I also got curious, when I read this for the first time. We don't use it in Ethiopia, but in the US and in Europe and in many developed countries, they use it especially for research purposes as well as for diagnostic purposes. Especially, it's very useful in cannabis. And then THC can enter into hair follicles and it gets accumulated in the hair. THC is tetrahydrocannabinol. That's a psychoactive chemical in cannabis. So, yeah, you can think about, someone who smokes cannabis with a long hair, THC in the hair, right? Very interesting. So the amount of THC in the hair is proportionate to the chronicity of cannabis smoking. So that is really a powerful test in a way. It shows you how chronic the person's cannabis use has been. If you just take a hair and then check the amount of THC in the hair, anyway, or its metabolites or whatever chemical you find in the hair. Very interesting. I know someone is laughing. I don't want to mention a particular group, but every time you see a long hair, you can think of, how much THC or its metabolite is in that long hair. Very interesting. I have another laughter emoji. Question number 4. A few words about benzodiazepine addiction and its management. Benzodiazepines are, again, as I mentioned earlier, one of the common prescription drugs that are misused. So when you have, different kind of benzodiazepines, we have short-acting benzodiazepines, intermediate-acting benzodiazepines, long-acting benzodiazepines. It could be lorazepam, midazolam, clonazepam, alprazolam, diazepam. You have different types of zepams. So if you find a person who has benzodiazepine use disorder, or in short, benzodiazepine addiction, the first step is to convert the benzodiazepine into diazepam. So there is a conversion formula. If you Google conversion table for the different benzodiazepines, you can find the equivalence of lorazepam to diazepam, or clonazepam to diazepam, or alprazolam to diazepam, or the different zepams. Change them into diazepam equivalent, and then start with that dose. And then you taper it over a period of 2 weeks, 3 weeks, 4 weeks, depending on the severity. It's advised to taper it slow. Sudden discontinuation can have exactly alcohol withdrawal-like syndrome. So we have to be careful. So change to diazepam, taper it slowly, reducing it maybe by 5 milligrams per day. Some people who have heavy diazepam addiction, I have seen someone who takes 150 milligram diazepam or its equivalent per day, because it's just like alcohol, I've seen people who take a bottle of vodka. Diazepam is same as alcohol, right? Their tolerance develops, so people take higher and higher doses. So, convert all benzodiazepines to diazepam, taper slowly, and stop at the end. It's a painful and difficult process, but it's possible. Okay. Question number 5. Thank you for the presentation, Prof. Please say a few things about the nuclear medicine, imaging, and so on. Imaging is really very powerful. I have shown you neurobiology of addiction using different imaging studies, functional brain imaging, structural imaging, like even CT and MRI can show some brain changes. But using functional imaging, hypofrontality has been demonstrated. The different brain regions that are involved in addiction have been delineated. The National Institute of Drug Abuse in the US is the largest research institution. It's a branch of NIH dealing with addiction. Nora Volko is a director of NIDA. She has done extensive research on functional brain imaging. If you Google Nora Volko, N-O-R-A, Nora Volko, V-O-L-V-O-L-K-O-W, Volko. She's a director. On neurobiology of addiction, especially using functional brain imaging, extensive studies and publications are available. Okay, so Google that. What's IMA doing to help physicians with substance use? This is my question too. I mean, I cannot answer this because I'm a member of IMA. I'm not in the executive committee, so I skipped this question, and IMA should answer this. I had a conversation with the president, Dr. Tagbar, in March, because I gave nearly the same CME, pre-conference CME, and he attended the session. I think he was present at the end when we had the discussion, and he expressed interest on the issue. I don't know whether he took it further or not. So question number 7, what should we do if there is a refusal to treatment? This is also a big challenge in addiction. Oftentimes, if you look at the global data, or take, for example, the US, only 10% of people who have addiction engage in treatment. So the treatment gap is 90%. In Ethiopia, I would say it's 99% because we have really very limited services. Even in the US, where you have a lot of resources and treatment, if my memory serves me correctly, they have 5,000 addiction psychiatrists. And the number of addiction counselors, psychologists, social workers is in thousands. Only 10% have access to care. So that's a big challenge. Part of the reason is the nature of the disorder or the disease. You know, the disease sits on the frontal lobe, on that decision-making part of our brain. And there is a saying, you know, who guards the guards, right? That's unfortunate. Judgment is impaired, executive functioning is impaired, decision-making is impaired. So the person thinks he's okay, you know, he doesn't think he has a problem. That's exactly my everyday encounter. Families bring a patient who has addiction to me. When I have a conversation with them, they usually tell me, oh, I have no problem. Use it like, you know, recreationally like any other person. What's the big deal? Okay. But we have a very important intervention called CRAFT, Community Reinforcement Approach Family Training. So we can train the spouse, we can train the parents, we can train, you know, concerned significant others. We call them CSOs, and we can give them a package of, you know, knowledge and skills to engage the individual. Family members who attended CRAFT sessions have been studied. There is 65% treatment engagement in people out of 100 who refuse treatment. When you do CRAFT with a family or CSOs, 65% engage in treatment. So there is an intervention, evidence-based, if we do it correctly. Any research about the relation of addiction to suicide? Of course, addiction and suicide are extremely related. In fact, people who have suicidal thoughts, they take different substances, especially alcohol, to get the courage. You know, it tips the balance to suicide. When someone who has suicidal ideations, when he consumes alcohol, his probability of committing suicide is much higher. And then generally, mortality is very high in addiction. The standard, if you calculate standard mortality ratio, when you compare people who have addiction with people who have no addiction, the difference is 20 years of life expectancy lost. So they live 20 years shorter. You know, different stories from the US, right? Recently, Matthew Perry, you know, he died. He was just 52 or 54. Michael Jackson died at the age of 50. Whitney Houston died at the age of 48 or 50. George Michael died in his early 50s. Prince died in his early 50s. Life expectancy in the US is on average 75, right? But people who have addiction, these celebrities, these people who have everything, live 20 years shorter than an ordinary farmer in the US. It's a killer disease. I know in our country, many people who died at a very young age. It's unfortunate. So it's a killer disease. The disorder kills them, and it's a slow death. In a way, it's an act of suicide, you know. They know the outcome. The last one is internet addiction, social media, and pornography. This is very common, and this is a challenge in the 21st century with the advancement of technology and an improvement in the internet. access to different online materials. Many young people are hooked to that. Internet addiction is being researched intensively. So in the next edition of DSM, there will be internet addiction as a mental disorder. DSM-6 will include, for sure, internet addiction as a mental disorder. Expect that, because it's undergoing extensive research and evidence is already accumulating. Thank you very much, and I wish you all the best with your CME tests, and I hope some of you will be stimulated, especially general practitioners, to join psychiatry and to do addiction psychiatry subspecialty. It's a very exciting and very interesting profession, and we help a lot of people. In fact, I have been privileged to be in this profession, and it's the most rewarding practice. Yeah, thank you very much.
Thank you very much, Professor, for your time and for the detailed responses. And there was one comment that was written for you on the Q&A box. It says, it's always a pleasure to hear you on addiction. Can we share the duration of therapies with medication for SUD clients, and which therapy is more effective on psychoactive substances? That's with warm regards from Dr. Matolo from India. I hope I pronounced that name
right. Shout out to Matlub. He used to be a colleague in AAU. He's a clinical psychologist. He was in our department. He spent 11 years in our department teaching psychologists and psychiatrists, psychiatry residents, and medical students. I'm sure some of you have been taught by him on psychological theories. Duration of treatment, I think, varies from substance to substance. Obviously, medications are used for two purposes. One is for detox. Detox is shorter, usually 1 to 2 weeks. Relapse prevention is a bit tricky. Medications help consolidate new healthy behaviors, and then they diminish craving, the intensity of craving. So we call them anti-craving medications. So any anti-craving medication that's used for less than 3 months is useless, because it does not help in the long term. So a minimum of 3 months and up to 1 year. That's how I prescribe these medications. We call them anti-craving medications. For alcohol, we have naltrexone, acamprosate, disulfiram. For tobacco, we have NRTs and non-NRT medications. For opioids, we have naltrexone. So I usually prescribe naltrexone for opioid use disorder, minimum of 6 months to 1, and then up to 1 year. And same for alcohol, 6 months up to 1 year. For tobacco, usually for 3 months, sometimes up to 6 months. Thank you very much.
Thank you, Professor. So now I will be sharing the quiz, so we can discuss the answers together. Is it visible? All right, so we can proceed with the first question. Would you prefer if I read it out loud, or would you want to address it yourself, Professor?
I read it myself. So the first question is, it's already on the slide. So I give you the answer, right? Is that what I should do?
Yeah.
Yeah. So common characteristics of psychoactive substances include all of the following except. They have pleasurable effects, yes. Route of administration doesn't affect the speed of effect. That's obviously wrong. With repeated exposure, tolerance develops. Yes. The reward system is profoundly reset, such that normal human pleasures and rewards become ineffective. Cannabis has the most aversive reaction to debut users compared to other substances. It's very interesting. You know what debut users? Debut is beginning, right? First time, debut. First time users, more than 50% of cannabis users report aversive reactions. Question number 2, and I may not go back to it again. Question number 2, all of the following are correct regarding brief intervention. Frames, I already discussed that. It's derived from motivational interviewing, yes. It's a very abbreviated form of MI. Takes about 5 minutes to administer and very useful for busy clinicians. Feedback is a key part of the intervention, yes. Discussing past experience is not necessary. This is wrong because self-efficacy depends on past successful behavioral regulation. When we discuss self-efficacy, we discuss their past successes. For instance, I used to discuss with medical students, finally, right, preparing for qualifying exam. I always ask them, how many exams did you take in the past? They tell me 500, 1,000. From kindergarten, it will be like over 1,000 exams. And how many times have you passed? They usually tell me more than 90%. So if in the past you've passed 90% of your exam, you have more than 90% of chance of passing this qualifying exam, and they have their aha moment. That's what self-efficacy is about. So discussing the past is very important. You can ask the patient, is there any difficult behaviors that you changed in the past? Something that you struggled with, but that you overcame. Person will come up with that. Look, you can quit smoking if you did that. E stands for empathy, that's obvious. Question number 3. Would you please move it up a little bit? Yeah, thank you very much. All of the following are correct regarding alcohol exempt. Screening for alcohol is important for any adult presenting for general health condition. I think I said it already. It's obvious. Question number 2, ophthalmoplegia, ataxia, and confusion are classic triads of Wernicke's encephalopathy. Again, this is correct. Heavy drinking is associated with adverse health outcomes, including addiction, obvious. Long-term treatment with anti-epileptic drugs is not indicated for alcohol-induced seizure. That's exactly right. I already said that. Audit is a diagnostic tool for alcohol addiction. It's not diagnostic. This is a screening tool. So E is the answer. Question number 4 is the last. A 45-year-old physician was rumored to have substance use disorders. His colleagues were worried about his health and the patient's safety under his care. The presence of the following signs may suggest problematic substance use, except one is a relatively rapid decrease in a colleague's competence at work. That's correct. Number 2, a newfound punctuality. That is opposite, right? I said newfound tardiness, slowness, lateness. So they often come late at work. So punctuality is wrong. Irritability is yes. Deteriorating personal hygiene, social isolation. So the answer is B. I think we're done with the questions, and I'm sure they answered them all.
Yes, thank you very much, Professor. We're very grateful from Yetena's team for the nice presentation, for your willingness to participate in this session as well. And the session was really informative. Thank you very much.
You're welcome.
Thank you very much, Professor. We'll definitely see you in 2024 with other sessions as well. We would like to say thank you for our participants. Have a good night. Thank you again.
Thank you.
Professor.
Bye-bye.
Bye.